Okay, good morning, everybody. Welcome to this week's AMSSM Sports Ultrasound case series presentation. We are continuing, as we mentioned, as Doug mentioned last week or 2 weeks ago. Sorry, excuse me, with our faculty portion of these presentations, and this will probably carry us through the end of 2021. So today we are exceptionally fortunate to have Doug Hoffman giving us another of his excellent talks. So Doug really doesn't need much of an introduction here. So Doug's out in Duluth, Minnesota at Essentia Health, has been doing exceptionally high level diagnostic sports musculoskeletal ultrasound for a long time, and is really one of the leaders in this field. And I know going through this whole case series with Doug and some of the discussions that we've had, he is absolutely exceptional with ultrasound, and I've learned quite a bit from Doug through this whole process. So we're super lucky to have him take some time to put this together, and I'm sure teach everybody quite a bit that they didn't realize, that they didn't know. With this. So his talk is on a lateral ankle injury in a soccer player. And with that, I'm going to turn this over to Doug.
Thank you, Ryan. And I do want to thank Ryan. Let me grab my screen here. Let's see. Oh, here we go. Are we good? Sorry.
I can't see your screen just yet.
Can you see it now or not?
I cannot.
Did you send it over to me?
Yeah, you should be able to. Your co-host.
Still cannot, huh? Which should I do?
What was it saying?
Let me see here. If I have to click on something. Let's see. It's not really saying anything. It's just saying recording.
Do you have on the bottom? Do you have the green share screen button?
Oh, I got it. Okay, I think we're now. Are we good?
Yep, perfect.
All right, sorry about that little delay. Again, thank you, Ryan in Iowa, for his exceptional coordination and organization of this case series. It's been seamless. I also want to give a shout out to Andy Meyer at AMSSM for his very good advertising on the various AMSSM platforms and putting these on the AMSSM YouTube. All right, so we have a case of a soccer player with lateral ankle injury, and the first of this series that Ryan did 2 weeks ago, he threw up these objectives. Again, because we're now with a new cycle, just quickly, that our goals are to review protocols for the complete exam, discuss these images and the pathologies in the protocol, and review a report. So extrapolating to this case, my goals are to demonstrate the importance of a protocol-based approach to lateral ankle pain, review the images, pathology, and discuss the report. So we'll jump right into the case here. So this is a 17-year-old male soccer player who sustained a right ankle injury after he was slid tackled from behind while in full stride. He was able to walk off the field, but he was not able to continue playing due to lateral ankle pain. Next morning, he could not bear weight. There was increased swelling and ecchymosis, which was predominantly laterally. Several days later, so this happened on a Friday, by Sunday evening, he was able to weight bear, but because of persistent lateral ankle pain, he called and was seen in our sports medicine clinic. The sports medicine physician that saw him obtained radiographs that just showed some mild soft tissue swelling and ordered a diagnostic ultrasound. And the and the order said lateral ankle injury. So when he came to our MSK ultrasound department, which is a separate department or organization, which was a week later, a brief exam at the time showed he had just mild swelling anterolaterally and some palpation tenderness over the anterolateral ankle, and then distal to the lateral malleolus in the subfibular region. All right, so the approach to this patient, and we've discussed many times in this case series, the importance of obtaining if they have not been obtained, and then reviewing prior to the sonographic value or radiographs. And so we see a little bit of soft tissue swelling laterally here, but otherwise these are normal radiographs. So what's my lateral ankle protocol? So most of my protocols start with joints. And in this case, these would be joints of the anterior ankle. And I've discussed my bias previously of the importance of assessing joints as they relate to the area that you're going to evaluate. So for example, my lateral hip, I do anterior hip images, including the joint, and so on and so forth. And so I first have 3 main joints that I look at, or 3 areas before I get to lateral structures. So let's just jump into that. And the first is the talocrural joint. And this is a long axis images. Obviously the tibia is to the left, the talus is to the right, and we can see the articular cartilage of the talar dome. Now the assumption is, this is a still image, and the assumption when I review images, let's say from my sonographer, or I'm taking these images in this case, that I've scanned dynamically the full width of the joint and that it was normal. And so then I'm taking a still image to represent essentially that I've done a full evaluation in the full width of that joint. And so we can see this is the anterior synovial recess. It looks normal. Now in this individual, I decided to go ahead and plantar flex as I look at the talocrural joint, and that's looking for a talar dome or osteochondral defect. And it's been validated that ultrasound is fairly accurate at visualizing OCD lesions of the anterior or mid portion of the talar dome. Obviously, the posterior portion is not uncovered even with plantar flexion. So in this particular individual, I sort of just added one image. And again, I scanned the full width of the talar dome in this situation, and then took a representative image. So that's my first image of my protocol. The second image is essentially a short axis of the talocrural joint. But not only is it a short axis, I get a peek at the anterior tarsal tunnel structure. So we have the extensor tendons here. There's a deep fibular nerve, as well as the extensor retinaculum. So again, dynamically, I'm going proximal to distal to get the full length of the retinaculum and the joint. But I'm taking a representative image because it was normal. And I'll just say that I also did that with plantar flexion and short axis as well. And this was all normal. And so we move on to the second image, and the second image is the dorsal talonavicular and naviculocuneiform joints. And then here we see the extensor digitorum brevis muscle overlying. And I'm looking for a number of things. And so I have found in the non-traumatic situation, particularly in the adults, it's not unusual to see a talocrural joint of, or talonavicular joint of fusion or degenerative changes. But in this individual, we see that there is hypoechoic thickening of the dorsal talonavicular ligament. And this is something I would not have found if this was not in our protocol. Now, to my eye, we have a change or hypoechogenicity of the fibular echotexture, but not discontinuity. Now, I learned from the masters early on in my ultrasound training that they seem to always have one hand on the color Doppler or power Doppler knob on the machine. So it's just reflex for me that when I see an abnormality, that I'll put the color Doppler on. And then second is that my sonographers are trained, and I always perform comparison images when I see a finding like this. So here's a comparison image, and here we see the dorsal talonavicular ligament and the abnormal ligament here. So like I said, I reflexively put the Doppler on, I lighten the probe pressure, I put more gel on if needed, and this does not show any vascularity of the dorsal talonavicular ligament. Now, why do I get this image? Well, the dorsal talonavicular ligament in acute ankle injuries is not uncommonly affected. And in fact, this prospective study performed a few years ago looking at ankle injuries with normal radiographs found that about 1 in 5 had an injury to the dorsal talonavicular ligament. So again, if this was not in the protocol, this would have been missed. And then the third image is probably not very intuitive to most people, but that's actually a medial tibiotalar and talocalcaneal joint image. So it's a straight coronal transducer orientation. And I'm looking at two joints. I'm looking at the tibiotalar and talocalcaneal joint. And again, one of my mentors taught me this image when I was starting diagnostic ultrasound, and I find this image very useful. And why do I find it useful? Well, looking at the tibiotalar joint, I have had a number of cases where synovial hypertrophy or synovitis is only revealed at the medial tibiotalar joint and not anteriorly. So that's not uncommon. Secondly, for those who've had previous ankle injuries, it's not unusual to see interposing bony fragments, of which some may be symptomatic. And then third is I get a bird's eye view of the deltoid ligament on this image. And why I'm not doing a detailed evaluation of the deltoid ligament here, I do again get a sneak peek. And if my eye catches any potential abnormality, then I'll go ahead and more closely look at the components of the deltoid ligament. And then the second image in this case is the medial talocalcaneal joint. And mostly what I look for here is a coalition. And again, why am I looking for that in a lateral ankle case? Well, about once or twice a year, I find an unsuspected talocalcaneal coalition. Now, they're the second most common type of coalitions, only second to the calcaneal navicular coalition. They're very difficult to diagnose on plain radiographs, and they can be associated with recurrent ankle sprains. So the classic presentation of this coalition is a rigid flat foot deformity, but my experience is that not everybody has that. And I would say about 80% of the coalitions that I find that are unsuspected relate to another problem in the foot or ankle or are symptomatic themselves. So through the years, I've kept this in my protocol because I find it useful. So I'm going to just present my report as we go along. And so I start out the report saying there is no talocrural joint of fusion. The medial tibiotalar, talocalcaneal joints are normals, and then structures within the anterior tarsal tunnel are unremarkable. Then I go on and say that the dorsal talonavicular ligament displays hypoechoic thickening without discontinuity of fibular echotexture. There's no associated vascularity. And we've alluded to, I know Ryan alluded to this with the presentation 2 weeks ago, that is absolutely fair game in these reports to state whether there's pain with sonopalpation when you have an abnormal finding. And so in here, I say there's mild pain with sonopalpation. All right, so now we're going to move on to the lateral ankle. And so this anterior structure is, it takes me about 3 or 4 minutes. So it really doesn't add a lot of time to the exam. And again, in my opinion, makes a much more complete exam. So again, they're probably not intuitive, but my first image in the lateral part of the ankle is a lateral subtalar joint. And many of you are familiar who do lateral subtalar injections with this image. And this image is a coronal and axial oblique orientation of the transducer with the calcaneus to the left and the talus to the right. And we see hypoechoic perineal tendons above due to anisoptropy. And why do I get this image? Well, again, in a 17-year-old who has an acute ankle injury, has trouble walking, an effusion of the subtalar joint would make me suspicious that there is a subtalar injury that might not be revealed with radiographs or ultrasound. In this case, it was normal. And interestingly, a couple of weeks ago, as I'm putting my PowerPoint together, I was referred this diagnostic ultrasound, and this was a 55-year-old female with posterolateral ankle pain, and she was referred for diagnostic ultrasound with a suspicion of a perineal tendon abnormality. And the entirety of the diagnostic ultrasound was normal except for fluid in the subtalar joint. And so if this was not in my protocol, I would have missed this. I went back and looked at radiographs that I had looked at previously, which were read as normal, and I kind of, and again, through the retroscope, looked at the subtalar joint, and I feel that there's probably some increase in subchondral sclerosis. And here you can see some subchondral cyst formation here. So this is probably subtalar joint arthrosis. Well, The provider asked us to do an aspiration and injection. The aspiration was non-inflammatory, and she got better with the injection. So again, by having this in the protocol, we were able to discover the source of the pain, which may have been difficult otherwise. And again, probably not intuitive, but the sinus tarsi is the second image on my protocol. And for those of you who are less familiar with the sonographic evaluation of the sinus tarsi, if you're on the subtalar joint and you rotate the probe 90 degrees and somewhat anterior and distal, you're going to be right on the sinus tarsi, which of course is a space. And so to the right, we see the anterior process of the calcaneus, which we all know can be injured with lateral ankle injuries. And then to the left of the screen, we see the talus. Now, a number of structures I think about with the sinus tarsi. So first is the anterior process of the calcaneus, which is also the origin of the bifurcate ligament. Now, the bifurcate ligament is not necessarily part of my protocol every time I do a lateral ankle. And so I call this the expanded protocol. So if I'm looking at the sinus tarsi and I'm dynamically scanning and things look fine, then I'll take a representative image and move on. It's also where the roots of the inferior extensor retinaculum attach within the sinus tarsi, and there are several ligaments of the sinus tarsi, including the talocalcaneal interosseous ligament and the cervical ligament, which the cervical ligament we can assess with ultrasound. And so again, even though I'm taking a representative still image, the reality is that I'm scanning, in this case, medial and lateral over the anterior process of the calcaneus. So this is a video of me doing that. And we see here that there's bony fragmentation of the anterior process of the calcaneus. So I'll just stop that and here, go back, and here we see some bony fragmentation and some surrounding edema. So now it perks my interest. And normally, again, I probably wouldn't look at the bifurcate ligament, but in this case now, I've expanded my sinus tarsi part of the protocol to look at that. Now, anterior process of the calcaneus fractures are thought to occur of one of two mechanisms. One is an avulsion type fracture of the bifurcate ligament with the plantar flexion inversion type injury. And the second is a compression type fracture from forced dorsiflexion eversion type injury, where the anterior process will compress against the cuboid or the talus. And so now I'm going to go to the bifurcate ligament, and most of you are familiar with the bifurcate ligament. Also, interestingly, there's an association between anterior process of calcaneus fractures and the dorsal talar navicular ligament injury. So again, sort of tying together some of the findings and some of the protocol images. So I'm going to go to the bifurcate ligament, and again, most of you are familiar that it has two components with its origin on the anterior process of the calcaneus. So we have the calcaneal cuboid and the calcaneal navicular bundles of the bifurcate ligament. And so I'm going to start just by putting my probe on the anterior process and looking at the calcaneal cuboid portion. And so normally we would have nice, tight, compact fibular echo texture in this comparison view, and we can see here that it's a slightly hypoechoic, but clearly thickened, but not discontinuous. And so again, just pointing out the comparison image here. And then I'm going to take and rotate the probe on the anterior process of the calcaneus towards the navicular. So that's what this video is here. This is the cuboid. This is the calcaneal cuboid, and now this is navicular portion. And what we see here is a sense an avulsion fracture of the anterior process as the bifurcate ligament attaches on. And again, my bias in these cases is to get a comparison images. So these are still images of that. Here we see avulsion of the anterior process, and then this is the contralateral normal side to highlight the injury. So it's not necessarily discontinuous, but clearly there's a avulsion fracture. Now, one thing I haven't mentioned with these ligament injuries is, one is you want to have them under some tension, and two is it certainly wouldn't be wrong with each one of these to do a little dynamic study to bring out more disruption that would not be conspicuous with still images. And so when I've taken these, I've slightly moved their foot to add stress to these images. So just want to mention that. All right, so we go to our report here, and the lateral subtalar joint is normal, and there's thickening without disruption of the calcaneocuboid fibers of the bifurcate ligament. There is also a avulsion type fracture of the anterior process of the calcaneus at the origin of the calcaneonavicular fibers of the bifurcate ligament. Surrounding edema is noted. Corresponding sonopalpatory pain is also present. All right, so then we're going to move on to more familiar structures. So again, I've discovered a few things I probably would not have discovered if my protocol was just ligaments and peroneal tendons. So we go to the anterior talofibular ligament, and I expected fully to see a tear of this ligament, and to my surprise, it essentially was normal. Tiny bit of fluid here, but otherwise normal. And for those of you in starting out, let's say new fellows, the proximal part of the probe would be on the distal fibula. The distal part is pointing to the big toe, and in this case, we would plantar flex. And then to get the anterior inferior tibiofibular ligament, we're going to dorsiflex and rotate on the fibula about 70 to 80 degrees. And now we see the anterior inferior tibiofibular ligament. And again, with the syndesmosis, I'm dynamically scanning proximal to distal, and this is a representative still image. And then we'll go to the calcaneofibular ligament. And again, the proximal end of the probe is on the distal fibula. The distal end is on the calcaneus with a slight posterior rotation. And so we see the contralateral side, and normally the calcaneofibular ligament is viewed almost as a sling under the peroneal tendons. And so I will typically put the ankle in the neutral position and then slightly invert the ankle dynamically. So it tends to, again, make the CFL a lot more conspicuous. And so when we do that in our patient, we can immediately see that the calcaneal end of the ligament is hanging in the breeze here. And so we have a complete tear off the calcaneal portion of the CFL. Now with this image here, I'm just going to mention, for those of you who are more advanced, I actually did look at the cervical ligament. We're not going to go into that, as well as look at the lateral talocalcaneal ligaments, particularly with the CFL tear. And so I didn't neglect those, but decided just to leave these out for now. All right, so our report, the anterior talofibular and anterior inferior tibiofibular ligaments are normal, and then there's a complete disruption of the calcaneofibular ligament from its calcaneal attachment. And then finally, I'm going to go to the peroneal tendons and sural nerve. In the peroneal tendons, I want to scrutinize the superior peroneal retinaculum, obviously look at the longus and the brevis, and then a dynamic eversion. And so what I decided to do in this case is, and what I do in all cases, is first do a surveillance in short axis proximal to distal to kind of get the lay of the land. Is there glaring abnormalities? So here I am above this, just right at or above the superior peroneal retinaculum. And then I am going to start scanning distally. And what my eye is catching is the superior peroneal retinaculum, in particular this hyperechoic triangle. And this hyperechoic triangle is the anchor for the superior peroneal retinaculum, and it's hyperechoic because it's fibrocartilage. And so that's an important structure for your eye to catch, because that's what essentially keeps the peroneal tendons from subluxing or dislocating anteriorly over the distal fibula. Now, as we scan more distally, we see that it becomes hypoechoic, and now we're wondering, is there a problem here? But actually, this hypoechoic triangle now is normal because there's a change from fibrocartilage to hyaline cartilage at the distal aspect of the superior peroneal retinaculum. And so again, this is actually normal, and don't mistake this for an injury to the retinaculum. We also see that the peroneal tendons look quite normal. And then another thing I look for is, as I get to the tip of the fibula, the muscle of the peroneus brevis should disappear. And if you see muscle this low or see muscle below the fibula, that's one of two things. Either it's a low-lying peroneus brevis muscle or it's a peroneus cordis muscle. And so as I continue around the malleolus, so you can see the fibula disappear, I'm now at the calcaneus and subfibular region, and the brevis is on the right, the longus is on the left, and then what we'll see appear that most people, but not all, have a peroneal tubercle. I look for hypertrophic changes of the tubercle, which are a risk factor for peroneal tendon problems. And then we see that the peroneus longus is hypoechoic. And again, that's normal because the longus then changes planes to go to the cuboid sulcus. And so you're not going to see both tendons in the perineal tubercle without anisotropy of one of them. So I decided in this case, because the perineal tendons look normal, I did not do a dynamic eversion maneuver. Obviously, if there was any abnormalities, I would include that. And I basically left this short axis distal to proximal videos showing that I've looked at both the retinaculum and the full length of the perineal tendons. And then we're finished up with the sural nerve here, which was normal. And we find the sural nerve traveling next to the lesser saphenous vein. There's just two quick points I want to make here. One is often with athletes that the retrofibular groove or concavity can make it difficult to use a linear array probe. So a fair amount of gel is often needed to fill that space. And in this case, I switched over to a hockey stick transducer, and sometimes the entirety of my perineal tendon evaluation will be with a hockey stick. And so those are just two tricks if you're having trouble getting good images as you look at the perineal tendon, specifically as they curve around the fibula. All right, so the superior perineal retinaculum appears normal. The perineal tendons, both within the supramalleolar and inframalleolar regions, this is just how I present them and read them, are unremarkable. The sural nerve is normal. All right, so my final report, in this case, a complete diagnostic ultrasound of the right lateral ankle, indications, and I usually just try to put what the referring provider said, status post 1 week lateral ankle injury. I usually put what transducers I use. Again, I use the hockey stick right at the end. I put correlation is made with any imaging study I might look at beforehand. We've already been through the body, so my conclusion is a partial thickness tear of the dorsal talonavicular ligament, bifurcate ligament injury, including a partial thickness tear of the calcaneocuboid fibers and an avulsion type fracture of the anterior process of the calcaneus at the origin of the calcaneonavicular fibers, and a complete tear of the calcaneofibular ligament. So in conclusion, my main goal was to basically present that if we stick with our protocol, we're going to get a full assessment of all pertinent structures, even less common ones. And so again, by sticking to the protocol here, I was able to see things that I might have missed otherwise. And so I'll just leave it there, and any questions or comments.
Hey, Doug, it's Ryan. So as always, after one of your talks, once I think I've got a pretty darn extensive examination of a particular region, I realized that there's certainly quite a bit more that I can do, based on the structures that you have shown in that region. I think I've maybe 2 points and a question. The main point, and we've talked about this previously, is, I think as all of us and as fellows are learning, these different regional protocols, lateral ankle, anterior ankle, posterior ankle, medial ankle, there's really a ton of overlap between these regions. And, one thing that you always point out is, you start with the joint, and for this example, for a lateral ankle protocol, I mean, you're certainly crossing way over into the anterior ankle and even some structures in the medial ankle, because they're all relevant for your lateral ankle protocol. So I think, as we go through this, having a protocol that is really specific for that patient presentation, and, not being, I don't know, concerned about, migrating over into a quote unquote different region, I think is really important to keep in mind. I guess the one question I had, and I don't think it's part of your lateral ankle protocol, but I've had a couple cases, mostly from a dorsiflexed everted injury, where people would have, or patients would have vague kind of posterolateral ankle pain, and they've had some pathology in the posterior inferior tibiofibular ligament. And I'm just curious, is that ever part of your protocol? Are you scanning that much? And if you are, do you have any pearls or tips on obtaining that image?
Yeah, that's a good question. It's not part of my protocol, but my protocol, for example, if this person had posterior lateral pain, I'm going to dig in more to the peroneal tendons. I'm going to potentially look at the posterior tib fib or posterior uh, talo fibular ligament. They're very difficult to find. They're deep, and I'm not sure if the reliability has been validated. I mean, there's certainly studies that show that we can find this, but whether it's been validated that we can see it on a consistent basis, to my knowledge at least, has not been done. And I tend that if I see pathology back there, so if I start to see disrupted fibers of the posterior tib fib or talofibular ligament, I'm probably going to go to an MR because there may be a more extensive syndesmotic injury than we understand. Oftentimes there can be occult fractures back there in that injury pattern. So that's one of those situations where I feel like ultrasound is a little bit less reliable. And I know there's some people that spend a lot of time back there and are good at it. But one, yes, like you said, is not part of my protocol, although I do look if if indicated, and two is that's when I typically go to an MR.
Yeah, that's super helpful. I have not been overly confident with scanning that structure. I like you said, it sits deep, and I'm not convinced I can do a full complete evaluation of the entirety of the ligament. So yeah, that's helpful. Thank you.
Yeah.
Let's see if there's any other questions. Anybody else have any questions, comments? So Doug, Tony Joseph has a question here. Any tips for following fibularis longus to its insertion?
Yeah, I mean, you can follow it to its insertion clearly. And it's basically then you're in the plantar foot area. It divides, and some people it divides up fairly quickly, and so you don't see all the slips. And in other people, you can see a pretty good tendon there. So I find it most challenging when you have, in an athlete like this, their foot probably is fairly soft, and just rub some gel in and on the bottom of the foot and just followed it around the cuboid sulcus. But sometimes when you get older people and have calluses, it can get a little demanding. But I think the only trick I use is I go right to the cuboid sulcus and then follow it from there. And if I'm doing an extensive peroneal tendon evaluation, I always look for an os peroneus as well at the cuboid sulcus and document that, and then from there go distally. So I don't know, Tony, if that answers your question, but I always start at the sulcus and just follow it.
No, that helps, Doug. I've had a hard time making that transition from the lateral ankle to the plantar aspect of the foot sometimes, and that transition always can be difficult, like you said, especially with very thick skin or other pathology.
Yeah, it is tricky, and sometimes you have to basically lay them down and so that you have full access to the bottom of the foot and then around that corner. But you're right, it is challenging, Tony.
All right. Any other questions, comments, concerns? Not seeing any. So again, Doug, thanks so much for doing that. As always, that was exceptional, highly educational, and I think is a really great review for all of us that are doing these scans. So thanks so much for doing that, as always.
Yeah, thanks.
All right, so that is a wrap for today. So thanks again to Doug. Per usual, we are off next week, and we will be back on September 3rd. Dr. Dan Leaders out in Pittsburgh is going to be presenting a case on a proximal rectus femoris tendon or myotendinous injury. So again, that'll be on September 3rd. Otherwise, everybody have a great Friday. Thanks for joining. And again, thanks to Doug. That was really great.
Have a good Friday, everyone.